Welcome to another episode from the Veterinary Medicine Digest. Today we are embarking on a comprehensive examination of feline head trauma, with a specific focus on a groundbreaking assessment of fracture distribution and the involvement of functional systems in feline patients. Trauma remains a pervasive challenge in feline medicine, often resulting in significant morbidity and mortality across various body systems. Due to the relatively small size of cats, it is remarkably common for them to sustain injuries to more than one anatomical region, and the head is frequently among the areas impacted. Interestingly, statistics indicate that the head is actually the second most frequently injured body region in domestic cats, following only the extremities in terms of occurrence. Most craniofacial injuries are the result of high-impact events such as road traffic accidents or blunt force injuries, though the phenomenon known as high-rise syndrome is also a common contributor to these clinical presentations. Understanding the complex nature of these injuries is paramount for the general practitioner and the specialist alike, because maxillofacial and traumatic dentoalveolar injuries can cause extreme pain and inflammation, while reducing the critical functions of the mouth and impacting a cat's overall quality of life. When we consider the initial approach to a cat that has sustained head trauma, we must first prioritize the major body systems before turning our attention to the more obvious facial injuries. It is very easy to focus attention on the more dramatic injuries like a proptosed eye or a displaced jaw, but it is vitally important that a thorough major body systems assessment is carried out on all trauma patients. Cats should be assessed for abnormalities in their cardiovascular, respiratory, and neurological systems, and management for these abnormalities should be initiated prior to completion of the physical examination and before any further diagnostics are carried out. Oxygen should be provided to all traumatized cats on initial presentation where their status is unknown. This stabilization phase involves assessing for hypovolemia by evaluating heart rate, pulse quality, mucous membrane color, and capillary refill time. It is a clinical challenge because cats often compensate well for small losses of blood but tend to decompensate earlier than dogs when faced with larger fluid losses. Signs like tachycardia with weak pulses and pale mucous membranes should prompt immediate therapy, keeping in mind that as the severity of hyperperfusion increases, cats may actually become increasingly bradycardic and hypothermic. Resuscitation typically centers on replacing lost circulating volume using intravenous fluid therapy, ideally starting with isotonic crystalloid fluids like Hartmann's solution. We must avoid hypertonic fluids in these scenarios because they are inefficient volume expanders and can encourage the formation of edema, which is particularly dangerous when a traumatic brain injury is suspected. While the cardiovascular system is being stabilized, we must also perform a thorough respiratory assessment. Facial trauma is frequently associated with trauma to the upper airway, which in some cases can significantly impact respiratory function, and feline trauma cases will also frequently have sustained injury to the thorax, such as pulmonary contusions or pneumothorax. Neurological assessment should initially focus on the mental status of the cat, and severe depression in the presence of normal cardiovascular and respiratory parameters should alert the clinician to the possibility of traumatic brain injury. Many cats with facial trauma will have some degree of traumatic brain injury, even if it is subtle, and this can range from mild behavioral changes to life-threatening brainstem involvement. Once the patient is cardiovascularly stable, we can move toward more definitive diagnostics for the craniofacial injuries themselves. For decades, the primary imaging modality available was conventional radiography. However, the feline skull is an incredibly difficult area to study radiographically because the bone structure is very complex and the superimposition of important structures makes a detailed examination of individual parts extremely difficult. To attempt to avoid the detrimental effects of superimposition, clinicians must acquire many different radiographic projections such as ventrodorsal, lateral and left and right lateral oblique views, which requires repeated repositioning of a potentially unstable patient. Because of these significant imaging limitations, computed tomography has become the gold standard for assessing feline patients who have sustained maxillofacial trauma. Computed tomography is much more sensitive than plain radiography for the identification of skull fractures due to the complex anatomy of the skull and the lack of superimposition achieved with this advanced modality. In fact, one study demonstrated that computed tomography could identify 4.7 times more injuries when compared with standard skull radiographs. Computed tomography allows for the precise diagnosis of fractures and provides a detailed description of their morphology and spatial topography, which is essential for accurate treatment planning. Now, we transition into our primary deep dive for today, which is a detailed study involving 48 domestic cats with acute craniomaxillofacial trauma. The objective of this specific research was to go beyond just cataloging broken bones and instead assess the fracture distribution and the subsequent involvement of functional systems using computed tomography imaging. This study focused on how these injuries impact the oral cavity, the nasal airways and nasopharynx, the orbiter and eye, and the neurocranium, including the tympanic bulla. The population consisted of 35 males and 13 females, with an average age of approximately 4.3 years and a median age of 3.3 years. The European Shorthair was the most common breed represented in this cohort. The results of this study were illuminating, showing that craniomaxillofacial trauma in cats causes multifocal and concomitant involvement of multiple functional systems. Fractures of the mandible had the highest prevalence, being present in 40 of the 48 cats studied. More than every second cat showed simultaneous fractures or separations of at least 2 different mandibular regions, and 14 of these cats had bilateral fractures. Fractures of the mandibular ramus occurred in 18 cases, while separation of the mandibular symphysis was found in 17 cats, and fractures of the mandibular body were seen in 15 cases. The study also highlighted the prevalence of Temporomandibular joint injuries, which were present in 27 of the 48 cats. These joint injuries included both fractures and luxations, with fractures of the condylar process being particularly common, appearing in 21 cases. Beyond the jaw, the study found that fractures involving the nasal and oronasopharyngeal airways were remarkably frequent, occurring in 36 of the 48 cats. These were the second most common type of injury after mandibular fractures. These fractures were typically comminuted and involved more than 4 different bones in half of the cases. 24 of these cats had bilateral involvement of the nasal structures. Maxillary fractures were present in 29 cats, and fractures involving the palatine part of the maxilla, which result in a traumatic split palate, were recorded in 28 cats. It is important to note that concomitant mandibular fractures were present in 26 of those 28 cats with hard palate fractures, reinforcing the idea that these are rarely isolated injuries. Furthermore, fractures of the osseous structures of the oronasopharynx, including the pterygoid and sphenoid bones, were recorded in 29 cats. Specifically, fractures of the pterygoid hamulus occurred in 25 cases, often leading to medial dislocation and secondary obstruction of the oronasopharynx. These oronasopharyngeal lesions were always found in combination with nasal airway trauma. The study also looked at fractures involving the orbita and eye, which were diagnosed in 30 of the 48 cats. Interestingly, all of these orbital fractures coincided with fractures of the nasal and oronasopharyngeal airway structures. Fractures of the medial wall of the orbita were the most common, appearing in 29 cats, and these injuries invariably resulted in a partial obstruction of the nasal airway. While retrobulbar and intraorbital swelling and an altered position of the eye were common findings, actual intraocular injuries were relatively rare, which aligns with previous reports on the subject. Fractures involving the neurocranium and tympanic bulla were much less frequent, occurring in only 6 cats, but they were always associated with more severe trauma and more extensive functional system involvement. When we analyzed the involvement of functional systems, the study found that the oral cavity was impacted in 46 of the 48 cats. This involvement primarily manifested as instability following a fracture, seen in 45 cats, and surrounding soft tissue swelling was detected in all of those cases. This primary damage to the masticatory apparatus implies significant mechanical difficulties during food uptake. The study also found that the origin of the masticatory muscles was fractured in 34 of the 48 cases, further complicating the functional outlook for these patients. The nasal airways and nasopharynx were functionally involved in 36 cats, where trauma typically resulted in airway obstruction due to narrowing of the cross-sectional area, dislocation of bone fragments into the airways, epistaxis, and soft tissue swelling. This not only increases airway resistance but also significantly impairs the cat's sense of smell, which is a critical driver for feline appetite. Perhaps the most important takeaway from this functional assessment is that the involvement of 2 or more functional systems was present in 36 of the 48 cats. Functional system involvement of the oral cavity combined with the nasal airways was found in 36 cats, and the involvement of the nasal airways combined with the orbita and eye was found in 30 cats. This multifocal involvement means that a multimodal therapeutic approach is essential for managing craniomaxillofacial trauma in the cat. We cannot simply focus on a single broken bone. We must consider the cat's ability to breathe, eat, smell, and see as part of the overall treatment plan. A critical component of this holistic management is the recognition of traumatic dentoalveolar injuries, which should be expected in any patient with maxillofacial trauma. In fact, the prevalence of traumatic dentoalveolar injuries has been reported to be as high as 72.1% in patients with concurrent maxillofacial trauma. The canine teeth, particularly the maxillary canine teeth, are more vulnerable to trauma than other teeth due to their prominent role in defense and apprehension. Enamel, dentin, and pulp fractures are common. and because the distance between the pulp chamber and the surface enamel is quite small in the canine teeth of cats, most crown fractures lead to pulp exposure. Unaddressed, these injuries can cause years of chronic pain and inflammation for the feline patient. Therefore, timely recognition and treatment are important for an optimal outcome. The ultimate goal in these patients is a rapid return to a functional, pain-free and inflammation-free occlusion. When it comes to treatment, the management of skull fractures can be divided into conservative and surgical approaches. Conservative treatment might be contemplated in cats with normal occlusion, good oral function, and fractures that are closed, stable, and pain-free. However, in cats presenting with mandibular or maxillary deviation, malocclusion, open fractures, or significant instability, surgical intervention should be considered. The main goals of surgical repair are the restoration of dental occlusion and the preservation of temporomandibular joint function, both of which are essential for feeding and grooming. One of the most common surgical procedures for cats is the repair of a mandibular symphyseal separation. This is often achieved through symphyseal wiring using a circlage wire placed caudal to the canine teeth. A large gauge needle can be used as a guide to pass the wire around the mandible, and the ends are twisted manually on the ventral aspect while the mandible is realigned. This technique is generally simple and effective, and the wire is typically removed after approximately 6 weeks once union has occurred. For more complex mandibular body fractures, clinicians may use interfragmentary wiring or plate fixation. Plate fixation is often recommended as the ideal method because the implant can function as a compression, neutralization, or buttress device. However, the presence of tooth roots makes plate placement challenging, and sizable implants may need to be positioned more ventrally to avoid damaging these structures. Non-invasive or minimally invasive fracture repair techniques should be strongly considered whenever possible to avoid iatrogenic injury to dental or neurovascular structures. The use of intraoral composite splinting is one such technique that can provide stabilization without the need for extensive surgical incision. Maxillomandibular fixation is another option, where the alignment of the maxillary and mandibular canine teeth is restored, and the jaws are fixed in a partially open mouth position using composite material. This allows the patient to breathe through the mouth and lap liquid food while ensuring the alignment of the jaws during healing. It is important to maintain an adequate oral opening, typically a gap of 10 to 15 mm between the incisors, to allow for these essential functions. The management of temporomandibular joint fractures and luxations is particularly complex. Fractures of the joint are often minimally displaced and can be difficult to stabilize with internal implants, so they are frequently managed conservatively if the dental occlusion remains adequate. However, if the joint is unstable or if dental occlusion is affected, temporary maxillomandibular immobilization is recommended. Closed reduction is typically the first step for joint luxations, involving the placement of a pencil or syringe between the molars to distract the joint and allow the condylar process to be shifted back into its normal position. In cases where the joint is severely damaged or where there is a high risk of ankylosis, which is a permanent inability to open the mouth, more aggressive interventions like a condylectomy may be required. Postoperative management is a vital part of the recovery process for these cats. Diligent assessment for pain and appropriate management of nutrition is essential, especially given that many cats will be reluctant to eat due to their inability to smell and the physical discomfort associated with their injuries. Force feeding is not appropriate for cats, and appetite stimulants are rarely sufficient to meet their full nutritional requirements during the recovery period. Therefore, it is much more appropriate to place a feeding tube at an early stage. Oesophageal feeding tubes are generally preferred as they are extremely well tolerated, associated with few complications, and easy for owners to maintain at home. Nutritional support should begin as soon as the patient is cardiovascularly stable. Analgesia is a non-negotiable aspect of trauma management. All cats that have sustained trauma should receive pain relief, typically starting with an opioid agent. Analgesia must not be withheld, not only for welfare reasons but also because ongoing pain is associated with central sensitization, which can lead to the development of difficult-to-treat chronic pain states. Non-steroidal anti-inflammatory drugs should generally be avoided in the initial stages of management due to the risks associated with their use in the presence of hypoperfusion. Once the cat is stable, these drugs can then be used to provide longer-term analgesia as required. In general terms, the prognosis for feline skull fractures and temporomandibular joint disorders is good, provided that the patient is carefully stabilized and managed with patience. However, cats with multiple mandibular fractures or significant internal upper jaw fractures have a higher risk of complications, such as malocclusion or implant loosening. Increasing age at the time of presentation has also been identified as a risk factor for the development of complications, possibly due to the presence of other comorbidities or more severe concurrent injuries. Long-term follow-up is necessary to monitor for signs of osteoarthritis, joint ankylosis, or chronic pain. This deep dive into the assessment of fracture distribution and functional systems confirms that craniomaxillofacial trauma in cats is a highly complex condition that goes far beyond simple bone breaks. The high frequency of concomitant involvement across the oral cavity, the respiratory system, and the orbital structures demands a sophisticated and multimodal approach to care. By using advanced imaging like computed tomography to identify all hidden injuries and prioritizing the restoration of function alongside anatomical repair, we can provide these feline patients with the best possible chance for a successful recovery. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.